Hi, today we're joined with Dr. Nate Lighthizer, where we're going to be talking about Down with OCT on the OI Show. Nate Lighthizer, what an honor and a privilege. Thank you so much for being on the show. If you could give the audience a little bit of a background on yourself and what you do most of the time, or what you spend most of your time on a daily basis.
Yeah, thanks for having me, Mile. Glad to be back on the podcast. I am at the Oklahoma College of Optometry. Hard to believe I've been there for 15 years now, 1 year as a resident, and 14 years as a faculty member, and now the dean of the Oklahoma College of Optometry. I spend the vast majority of my time, all of my time, in ocular disease clinic, laser procedures, injections, eyelid procedures, dry eye, and glaucoma and retina, doing a lot of OCTs, OCT angiographies. I was in diabetic clinic this morning and saw a variety of patients. So that's a little bit about my background here at the Oklahoma College of Optometry.
For anybody that's ever been certified to use lasers and or injectables, you've probably either directly been involved in some of those educational efforts or had a heavy fingerprint in the course content on that. So thank you for everything that you do. And part of this is actually going to be related to some of that. And I wanted to do a deep dive with you, Nate, because when I hear you lecture and talk about glaucoma, I love the practical aspects that you always share with the audience. And what I wanted to do a really deep dive on is some of the diagnostic technology we have, specifically advanced OCT, and how we utilize that for diagnostic purposes and also for monitoring these patients once we start treatment, regardless of what that might be, medication, laser, advanced surgeries, whatever that might be for these individuals. And when we look at OCT and OCT angiography, and we're looking at how we're leveraging a lot of these tools, we just see that every single company is making these technologies better. And what that means is faster, more scans in a given period of time that are much more accurate as well, too. And a lot of the buzz around our world is retinal nerve fiber layer and ganglion cell complex. Give us a little bit of your kind of perspective around that. What should we clinically, when we're asking our technicians to get these measurements, what are some of the highlights or clinical pearls that we should be thinking about when we're looking at the nerve fiber layer analysis and we're looking at the ganglion cell complex, and how can we leverage these things to better diagnose our glaucoma patients?
Yeah, I think the first thing is get it. We've got to have this data. There, as you know, Mile, there is no perfect test in glaucoma. We do OCTs, retinal nerve fiber layer, ganglion cell, visual field, pressures, gonios. We have all these different tests, and we look at structure and function to add up the picture and make a decision. When it comes to the OCT, I think it's fairly well stated that it is standard of care at this point. Get that ganglion cell analysis, get that retinal nerve fiber layer. Mile, when we were in school, I'm not sure that we talked about the macula in glaucoma 20 plus years ago. And now we realize that may be one of the first things that changes in glaucoma is that ganglion cell analysis. So when I look at the ganglion cell analysis, I look at that in depth and where is that thinning? What does it look like? Is it inferior? Is it superior? Is it respecting that horizontal midline, that raphe, or whatever you'd like to call it? But I look at that, and that carries a lot of weight for me early in the disease when I'm splitting hairs. Is this glaucoma? Is this not? I'm going to look at the retinal nerve fiber layer as well, but the literature guides us, and my clinical experience fits with this as well. If one of them is going to change first, it's probably ganglion cell analysis that may change before retinal nerve fiber layer. There are exceptions to that, but I look at the ganglion cell analysis, and that carries a lot of weight for me. When it comes to the RNFL, there's a lot of numbers on the RNFL, and you look at the overall number. We're all familiar with the overall number, but don't just get caught up in that. I start there, but then what's the quadrant analysis look like? What's the clock hour analysis? What's the T-SNP curve? And don't forget about those optic nerve metrics. We all know big nerves, big cups, big discs, big cups, small discs, small cups, and that can judge. Just because a patient has a 0.75 cup doesn't mean they have glaucoma. They may have a huge nerve, and you can use some of those metrics as well. So it's really looking at the entire picture. And the more you do this, the more comfortable that you will get those scans, ganglion cell analysis and retinal nerve fiber layer.
Nate, I think, one of the things, and this is great about all software that we utilize, they all kind of base their normative database on normals, and they say this is what we expect the normal range to be, and it'll usually create some form of color or picture for us clinically to say when we're scanning somebody initially, all right, this is what normal looks like, and this person falls within or outside of that normal range. And that can sometimes be deceptive. How important is it clinically, do you feel, that we are comparing, when we look at the nerve fiber layer or the ganglion cell for that matter, superior versus inferior intra analysis, but also to comparing the results to the other eye as well to see if there are differences in our overall analysis of all of this?
Yeah, I think that's critical because we were made and should have been made fairly symmetrical. And when I start to see a difference between about 7 and 9 microns between the eyes, if we scan your eyes, scan my eyes, Mile, they're probably not going to give us the exact same numbers overall and in all the quadrants. But when I start to see a difference of 7 to 9 microns in between the two eyes, and when I start to see change inferior, superior, again, those should be fairly symmetrical as well. That red flags me. And going back to your previous point, I think it's important, and I know it's tricked me up in the past. I think a lot of times we overdiagnose glaucoma, and we have patients that are maybe being treated that didn't need to be. Now, we certainly don't want to miss them, but just because your patient is not in the green doesn't mean that they have structural disease. It means they are a statistical deviation from normal, at least what we think the middle of the bell curve is,
Yep.
that normal. It's just remember that not all normals are going to fall in that quote unquote green range. There's a small percentage of patients that will be in the red or the yellow, just because that's where how their eyes were made. So remember that you can have red disease. I'm sure we've all heard of red disease where they don't have pathology. I just saw a 32-year-old real estate agent that had been diagnosed with glaucoma at 27, and she is red all over on her OCT. But the glaucoma specialist and I think it's red disease, that it's not pathology. I think it's important to remember that glaucoma is a progressive optic neuropathy. So look at the overall number, look at the quadrants, look at the clock hours. That's superior, inferior, I think is very important, and inter-eye, as we've said.
Nate, you bring up another great point, and that is, so you see somebody, and I think the beauty with a lot of this more advanced software, especially on the OCTs nowadays, is you actually can measure things over time.
Mhm.
And these software systems are at the level where they're so advanced that they can show us whether or not there's changes that are occurring globally and also locally in various regions. For the person that you just talked about, the individual who has the quote unquote red disease, and you're looking and you're saying, maybe they're just reduced, and you're following them over time, how important do you think it is to look at that software analysis over time and see what the trends are to help us better diagnose these individuals, or more importantly, if they are diagnosed with glaucoma, determine whether or not there is change and if we need to change treatment for those patients?
Yeah, we are really missing an extremely valuable tool and asset of the OCT if we're not using progression analysis. We've got to let that very sensitive instrument that can detect microns of change, let us show us that over time. Don't just rely on us looking at here's one printout, here's the other printout, and try to add up and compare the numbers. Let the software do that progression analysis for us. And it's very, very good at that to be able to detect, is this changing over time? There's going to be a couple of baseline scans that you've got to get, but then further down the line, has there been any change? You're really missing the boat if you're not using your progression analysis to assist you in that glaucoma. And again, this is a progressive optic neuropathy, and we often have time. I think that's the key. And another take-home point in all this diagnostic test, Mile, whether it's visual fields or OCT, get another data point, get another OCT, get another visual field. Time is usually on our side. These patients, I told a patient today, a 47-year-old female, that this is a disease of years and decades, not weeks and months. She came in with a pressure of 34 in one eye and 33 in the other today. and I'm going to do an SLT on her, and we're going to start on a couple of drops. But she hasn't shown much progression in the last 2 years, even when her pressures have been in the high 20s and low 30s. So we've got some time usually to get more points, and that can assist us in progression.
So Nate, all great points. Here's something that I'm going to ask you to, I think it would be awesome to get Dr. Nate Lighthizer's flow on OCT analysis because it's a lot of data. It's a
Yep.
lot of data.
Yep.
So what's your flow, Nate? Do you look at the measurements from today on a single layout on your screen and then look at progression if you have that time analysis? Do you focus on something else? What's Dr. Nate Lighthizer's flow
Yep.
on how he analyzes this information in an efficient way or manner?
My eyes first go to the overall number. And when I analyzed one today, I look, okay, what overall, how we doing? And it was 82 microns in the left eye and 62 in the right eye. So immediately going, we've got some asymmetry here. So overall, big picture, how does the eyes look like? Overall, right eye and left eye. And then I will immediately go down to the clock hours because glaucoma is an inferior superior disease usually. So I go from the overall number to the clock to the quadrant analysis and then
And
down
you're
to
looking at the nerve fiber layer analysis, right,
correct.
Nate? What you're talking
Correct.
about
I'm
now?
looking at the nerve fiber layer analysis on that printout, kind of a retinal nerve fiber layer in both eyes. So from the overall to the quadrant to the clock hours, then I'll go back up and I'll look at all those metrics about the optic nerve. What's the disc size, things like that, and then the T-SNIT curve. That's kind of how I look at that. Here's today's printout. Here's how it looks. And then if I've got progression analysis, I will look at that as well. How have we progressed since our last scan?
And Nate, I'm assuming you're doing the same thing with the ganglion cell complex as well, too,
Correct.
correct?
Yep. Yep. Very similar with the ganglion cell complex. Yep.
Nate, one other question for you. And, now it's really, really interesting that we can actually see vasculature in our OCT scans in a way that we've never been able to before. It's amazing that OCT scans can take multiple cross-sectional cuts of the same piece of tissue, analyze those things, and determine where blood vessels are based on whether or not there's blood moving through the blood vessels and recreate it to us as an image where we can see vascular supply in regions and areas. And we're using this in the macular region. Tell me how you're currently using it with your glaucoma patients, and also tell me where you think the future of OCT angiography is in managing and caring for our glaucoma patients.
Yeah, I think we are still very much learning about OCT angiography in glaucoma. We were part of a couple of clinical trials where we scanned a bunch of normals and a bunch of patients that had pathology, including glaucoma, just to get an idea of how this works. Those vessel densities around the nerve. Is it the vessel density that goes and then the nerve fiber layer that follows that, the nerve fiber layer loss? Or is it nerve fiber layer loss that precedes the vessel density loss? I think we're still learning on that. My intuition is I think maybe the vessel density is going to go first, but we're going to learn more as we do OCTA and glaucoma. Right now, Mile, we're kind of dabbling in this. It's not our standard that we do this in every glaucoma patient, but if we're really splitting hairs and trying to figure out what's going on, we'll get an OCTA to see what that vessel density metric looks like around the nerve. So again, still figuring out, still learning. I think it goes back, Mile, to maybe 20, 25 years ago when retinal nerve fiber layer, we were learning about this with OCT and ganglion cell. I mean, it used to
Yeah,
be visual field. You looked at the nerve and, oh, now we've
yeah.
got this OCT scan that tells us about retinal nerve fiber layer and ganglion cell. Again, this is 15, 20, 25 years ago. I think we're going to look back and go, and we were really in the learning days right now of OCT angiography and glaucoma. So that's how we're utilizing it at this point. Still learning, still dabbling. We're in our infancy stages of OCTA and glaucoma.
Great insights, Nate. I really appreciate spending some time with us and sharing some of that expertise because as the technology becomes more advanced, I think we start to depend on it more. And all of these little insights, I think, help us all. And the more we talk about this, the more comfortable we all get with it. So, Nate, thank you for being a guest on the show today.
Thanks, Mila. I appreciate it.
And thank you all for joining us on Down with OCT with the OI Show.